Hello and welcome to Chapter 2 review of the Economics of Women's Health. This is going to be a supplemental piece of information to accompany with the chapter, and I hope that you will find it very informative. Keep in mind that the PowerPoint slides are not all encompassing of the chapter. You still will need to go and review the material on your own, but this mini lecture that I generally share in 15-minute increments will help you to understand some of the components a little bit better. Okay, so let's get started. Healthcare in general is just expensive. As of when these slides were composed, you're looking at over $9,000 a year. And several years later, of course, I'm sure those costs have gone up. So an estimation at the 10,000 range would not really be unrealistic. So who's going to pay for this? Why are the costs rising? Why do your premiums increase every year when you don't seem to be getting more services? Or are you getting more services and you just don't know about it? So what's going on? How are we going to pay for this? Who is paying for it? What if you can't afford it? What if you want to have a baby? What if you get cancer? These are all aspects that impact healthcare. And for women, we also have some unique aspects about our healthcare that are going to be important for us to understand so that we can put ourselves in good financial positions. Because let's face it, one of the things that drives people into bankruptcy is medical debt. It is expensive. So in consideration of those things, let's look at some of the other questions as you follow along. How should healthcare be paid for? Whose responsibility is it? Is it your responsibility? Is it an innate right? Should you pay for it if you have money? But if you don't have money, then you don't pay for it. Is that not fair? Just because you don't have money, that someone else should pay for it? What are the services that should be offered? Should the government pay for emergency and critical care services, and then basic maintenance and care? Should you pay for that? What are some of the other factors that influence care? How should the costs be contained? Should they be capped? Because we have rent control in certain areas. I mean, these questions can literally go on forever, and there is always going to be debate and a non-consensus with each and every last one of these. Having said that, universal healthcare is not new. Sometimes because we don't have certain things in the United States and other countries do, if it becomes introduced here, then it may not seem as a normalized practice. But several of these aspects are actually very normalized, and this is not an advocation one way or the other. It's simply a fact that there are other countries where the government does pay for the healthcare. There are places where it's private insurance, such as here, or your job. The individual pays for it. So these are not new questions, but they will always be debated, and they will be hotly debated at that. We generally see things of this nature come up during an election cycle or when a public official is running for office. It's generally a part of their platform because healthcare is integral to people being able to live healthy and sustaining self-sufficient lives. So it's a natural platform and a natural question that will come up often. We look at the U.S. healthcare system. These are some aspects that I really would like to get a little bit deeper into. So a third-party payer system, we have this fee-for-service model. I give you money, you give me service, and all is supposedly well. Then we have the managed care model, and with this comes some stark advantages and disadvantages depending on who you ask. We have with this model a decreased access to care, which of course is never good, particularly for individuals who are in rural areas or who don't have ready access to their physicians or a clinic already. Decreasing that access is going to be even more catastrophic for those individuals. And then we have shorter physicians' office visits. Now, this one right here, everyone should have a problem with, because there are very few areas or very few hospitals and doctors' offices where you can go, and as soon as your appointment time comes up, they usher you into the room. I have waited on many an occasion for 45 minutes for an appointment that I had scheduled. So this shorter physician office visits presents as a very large problem because people are already waiting long periods of time to get care, and then the time that they're actually able to spend with the physician is significantly decreased because of numbers, because of whatever the issue is. We don't have the time that is necessary to be able to ask pointed questions and to improve our own health and become more educated about things that directly impact and benefit us or are to our detriment. And then we have higher copayments. I personally don't understand this model myself because I pay a premium every single month. Why do I need to pay a copayment? What is a coinsurance? What is a deductible? I had to pay something else at UCLA. It is fees on top of 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 the premium. So it's not really even just the higher copayments, higher everything. And then restrictions on choice of doctor. Even if you have a PPO, if you don't like anyone there and go out of network, say out of network with Blue Cross Blue Shield, you can go somewhere else, but they're only going to cover it at half costs. And those costs are passed on to the consumer. And once again, depending on what type of care you need and the standard of care, this can be a huge issue that oftentimes drives people into bankruptcy with medical debt. This particular graph shows the national health expenditures from 1970 until 2020. And of course, some of the costs have been estimated, it's a projected cost, but look at the massive increase in overall costs as far as medical expenses in the United States. This is just, it's unfathomable. And some of this is due to advances in medicine, absolutely, because we can detect things earlier, we can treat things better. There are advances in oral medications, advances in surgery. So some of these costs, a lot of them are actually warranted. But with that, we have what the consumer is paying. And even though it's outside of the scope of this class, the wages haven't necessarily caught up with the cost of living or the cost of medical care. And this is one of the reasons why it's so important. It's expensive to be unhealthy. It is expensive to be poor because the cost associated with treating your disease versus what you make and bring in is such a large ratio compared to other people that when you don't have resources, it becomes more expensive actually to live and care for yourself than other facets of the United States. So this graph is just indicative of how expensive and how much people have been charged and how much we've reaped the benefits of technology when it comes to medicine as well, but also what it is doing to cripple individual finances and fiscal outcome. And this is probably one of the main reasons behind the arguments for universal health care. And so I'm not going to argue the economics of that right now or the politics of it. Looking at this third payer party system, do you see how this cyclical effect really, at the end of the day, comes down to money? I pay you, you pay this person pays this company, the company pays the doctor, and it's just this vicious cycle. And of course, it's not that simple, but at the end of the day, you notice that these costs are directly related to services that are provided, but not just the services that are provided from the physician's office, also the administrative costs, the cost that it takes to upkeep the building. You pay for all of that, and that gets passed on to the individual. And sometimes we don't understand that because we don't see that reflected in our care. And it's completely understandable why there has been an outcry over premium increases. A couple of years ago, I decided that reading wasn't fundamental to me and just felt that I don't need to read the changes in my health insurance. And my premium was going up from $128 to $454. Now, I anticipated a $20, $30, $50 change. That happens every year. This change was several $100s. And because I didn't read the form, I ended up having to pay $454 for my premium, not counting co-payments, co-insurance, facility fees, deductibles. I $454 a month. So these premiums that we pay to the insurance company, who pays to the provider who provides a service, that is included in the premium, but obviously there are some costs missing or costs that need to be recouped, and that's why we have things like co-payments and deductibles, things of that nature. Now, the ACA or Obamacare, this is a general overview of what it does. Once again, as I stated in the first slide, universal healthcare is not a new thing. So it's an evolution. It's just growth, but not anything new. More Americans under this act would receive health insurance. And of course, some years later, the law has changed as far as the fines that are associated with not carrying insurance. But at the time these were written, this is what the law called for. It also requires insurance companies to expand coverage. You could not give a person insurance because they had a pre-existing condition. So that's huge because pre-existing conditions are costly, but sometimes a pre-existing condition was just something that you had to look out for, but didn't necessarily mean you were going to attain. For example, I have several members on my mother's side of the family with breast cancer. That is considered a pre-existing condition for me, and many insurance companies could actually deny me insurance if I reveal that information. And so part of this act was supposed to neutralize aspects like that to provide healthcare for people who otherwise would have been denied. And we also look at increases for government coverage of poor and individuals who are living below or close to the poverty line. There are exchanges, and each state can offer care for that particular state, or you can buy insurance individually through your employer, or your employer may give it to you, or you may supplement it. There's a lot of different things, a lot of different scenarios. And then in very few cases there was a reduction in some of the Medicare payments, but that generally did not happen on a large scale. The types of insurance, of course, you have your private insurance, and that's what you get through your employer, or if you were to purchase insurance on your own, that would be considered private health insurance. And then you have the public health insurance, which is government funded by the state, by the federal government, or the VA, the Department of Defense, Bureau of Indian Affairs, or a variety of other entities that provided health insurance for their employees or constituents. So by and large, it's really your employer pays for your insurance, or you pay for it, and sometimes the government pays for it. And there are pluses and minuses, of course, with all of those aspects. This graph breaks down round about the percentage of people where they get their medical insurance from. Of course, the numbers fluctuate. It's always a liquid type of statistic. The employer here, of course, as we talked about previously, provides a large portion of insurance for individuals. And then other private, Medicaid, other public. And then we have round about 17-18% of people who are just uninsured. Of course, this fluctuates. We're dealing with a national pandemic now, so I would suspect that these numbers would be drastically different by the time the reports came out at the end of the year. Now, for managed care plans, these are kind of an effort to cut healthcare costs by insurance companies. It ain't really working too well because my costs are high as hell. But in managed plans, companies kind of place limits on certain things, services, fees. There's a cap. So you have PPOs, and they have a little bit more flexibility as far as who you can go to. You're not as restricted. You have point of service. So I give you $10 for this shot. You give me the shot and deuces. And then you have health maintenance organizations, HMOs. They function in many ways in the same capacity as a PPO, but with some restrictions. For example, Kaiser is an HMO because everything is in-house and network, versus if you have Anthem Blue Cross, you can go see providers in a variety of different places. And then you have your high deductible plans. That's always fun, where you have to pay $1,500, $2,000 before your insurance will kick in. And there are also things such as a health savings account where you can put away money pre-tax, or if you have a particular benefit with your employer, they also would provide you with an account to where either they gave you a set amount of dollars and then you put money in, or they matched it. There's a few different scenarios, but these are some of the managed care plans that we have. And also they go into how you choose your insurance. So factors that you really do need to keep in mind are pre-existing conditions. Which one is going to be better to manage your condition? Do you need psychiatry, psychology? Do you want to look at non-narcotic medicines, alternative therapies? How much is the copayment going to be? Because my copayment is high. What are the prescription plans and providers in network? Are they enough or sufficient, educated, trained enough to be able to deal with your particular issue? So I hope this has been informative, and I look forward to seeing you in part 2. Bye-bye now.